Hi everyone, my name is Jenna and I'm going to be presenting an application of the patient-level prediction framework and software we've been developing within the OHDSI patient-level prediction workgroup. So, we've actually developed a standardized 5-step process for developing prediction models within the workgroup. It starts with defining the prediction problem, ends with the validation of the models. Now, our aim was to standardize this process so that we could really utilize the fact that we have the network of researchers and data sets, because the way models are developed right now, it's very hard to actually validate a model externally. So I was reading one paper that said generally it can take up to 3 years before a model is replicated and validated on other data sets, which means that it's hard to actually see how good these models are, how well they generalize. But with our community, of our network of researchers, we can really improve on this. We could do the network studies, and by making sure that we do a standardized process, we can make sure we've got transparent and reproducible models to enable this. Now, there's lots of different areas for the prediction problems in healthcare. We've standardized our problem question. So our problem question is, amongst some target population, the people you want to do the prediction on, which patients will experience some outcome during some time at risk? And the most common prediction area you'll see this being used for is disease onset and progression. So this is trying to predict who's going to get some new condition or some advanced or complication within some time period. But you could also look at treatment choice. So given someone has a new condition diagnosed, can we predict which treatment they would have been given? You could look at treatment response. So given someone's given some new drug, can we predict whether they're going to have some positive effect in the future? Treatment safety, which is going to be the focus on the rest of this presentation, and this is given a new users of a certain drug, can we predict who's going to have the absolute risk, not the risk due to the drug necessarily, but the absolute risk of some potential adverse event in the future. And then we've got treatment adherence. So this is given some chronically used drug, can we predict who's going to have some certain level of adherence in the future? So you can see all of these questions can be put into our standardized form of amongst target population, predict outcome in some time at risk. I want to make it very clear that when we do patient-level prediction, we are not doing causal inference. So it's very risky to interpret your model and come up with causal kind of risk factors. That's not what should be done. You're simply doing a risk model to assign a risk of some future event. If you want to do causal inference, then population-level estimation is what you should be doing. Now, there's a drug, sertraline. It's used to treat major depressive disorder, so it's an antidepressant. It has a black box warning of suicidal thoughts and behaviors in the young adult and pediatric population. On the label, it says that this occurs in about 3% of the population. So we could visualize that by saying, okay, if we had 1,000 people, we'd expect 30 of those to actually have the suicidal thoughts and behaviors in the following year. So these are represented by these people in red. Our standardized question becomes, amongst patients who are new users of sertraline, which patients will experience suicidal thoughts and behaviors in the year that follows the exposure? So can we discriminate the people from red from the rest of the population? Following our 5-step framework, we needed to pick a suitable data set. So we decided to pick a private payer claims data set, has inpatient, outpatient data, and it's a US data set. In that, we found there were 67,720 new users of sertraline. We wanted them to have 3 years of history because we're going to be using this as their baseline characteristics for the variables. They had to have had major depressive disorder. Out of that population, 2,050 of them went on to develop suicidal thoughts and behaviors in the 1 year that followed the exposure. We've created a way of extracting variables from any common data model or AMOP common data model using like the demographics and all the concepts that they have. We decided to pick demographics such as age and gender, index month, because there might be temporal trends. And then we also looked at things like conditions, drugs, procedures, and measurements in the prior year and all time prior. We also added risk scores. These are actually like calculated automatically. If you say you want any of these risk scores, the framework we developed will automatically calculate for you. And we included concept counts, like the number of visits, because this gives you information about the healthcare utility for each patient. We chose a lasso logistic regression model, and we use 75% of the data to learn the model, and then we validate the model internally on the remaining 25% of the data. So we'll look at what the prediction of the model on that 25% of the data compares to the actual ground truth. And this tells us how good our model will actually do. The first thing to do when you're doing a prediction model is it's useful to actually look at your data. So we did a clinical characterization where for every variable in the data that we extracted, so all those demographics and all the conditions and drugs and so on, we looked at how common they were in the people without the suicidal thoughts and behaviors on the x-axis, and how common they were for the people who had the suicidal thoughts and behaviors on the y-axis. And this tells you basically for each variable how well it by itself it discriminates between people who are going to have the suicidal thoughts and behaviors and who aren't. So if it's not able to discriminate by itself, it will fall on the x equals y line. If it goes above the x equals y line, it means that it was more common in the people who had the suicidal thoughts and behavior. And for example of this, we saw the child examination, which fits with what the black box warning said, that it's more common in the young. If it falls below this line, then it means it's more common in people who don't have the suicidal thoughts and behavior. An example of that, again, is the breast cancer, which is a proxy for age and fits in with what the label says. Now, this gives us some hope because you can see there's a lot of dots away from the x equals y line, so there seems to be quite a lot of differences between the people who have the suicidal thoughts and behaviors and those that don't. So this is going to give us a bit of confidence that we might be able to do a model that predicts well. And it turns out it did. So when we trained our lasso logistic regression on the 75% of the data, it picked 209 variables out of a potential 53,000 as being sufficiently informative and useful for the model. So that it achieved a good discriminative ability. It had an error under curve of 0.81, which is actually very good. Error under curve of 1 is perfect discrimination, so your prediction is perfect. Error under curve is 0.5 is random guessing. So an error under curve of 0.8 is actually incredibly good. But let's have a look at some points on this curve and see how they could be used or what they could tell us about these people. If we looked at people that the model predicted a risk of 6% or higher of having suicidal thoughts and behaviors in the next year, we found that would identify 50% of people who actually go on to have suicidal thoughts and behavior. And the positive predictive value is 12%. So the average risk for the population of suicidal thoughts and behaviors was 3%, but in this group of people who had a risk of 6% or higher assigned to them by the model, 12% would go on to have it. So this is 4 times higher than the average. We could also look at a higher risk threshold. So if we looked at the people who had 20% risk or higher, this identified 9% of the people with the suicidal thoughts and behaviors, and we had a positive predictive value of 26%. So 26% of those people would have got suicidal thoughts or behaviors recorded in the year that follows exposure. Alternatively, we could look at people who have the low risk. So if we look at people who had a risk assigned to them of less than 1.5%, then this is 50% of the population, but only 10% of the outcomes. So they have a very high negative predictive value and a much lower risk than the average. Another metric you need to look at on the test set when you're doing prediction models is the calibration. The calibration for prediction models is how well your predicted risk matches your true risk. And the way we actually determine this is that we line everyone up based on their risk assigned to them from the model. So people at the front of the line, the people who have the highest risk, people at the bottom, back of the line, the people that had the lowest risk assigned to them by the model. We then split everyone up into 10 groups. So we take the top 10% and the next 10% and so on. And each of those groups, we calculated that average predicted risk assigned to them from the model, and we compare that with the actual observed number of people who have the outcome in that group. And these give you 10 different points. If they fall on the x equals y line, it means your prediction's matching your observed. So you have a well-calibrated model, and that's what you want. In our case, we found that we did have this. So our model's well-calibrated, it has good discriminative ability, it's doing pretty well. But we don't want to also stop there. We want to look at whether it's calibrated well across age and genders as well. So we do a similar thing, but instead of ordering people by their risk score and using that to kind of create the groups, we actually group people by their age and gender, and then in each age and gender group, we say what was the average predicted risk and what was the observed fraction of people that have the suicidal thoughts and behaviors. The observed is plotted in red, the predicted expected is in blue, and we can see here that we actually get an overlap between the blue and the red, so we're matching the trend, and we're well calibrated across the age and genders by a model. You can also see that it's clearly the younger populations that have a higher risk, which is what the label said, and our model has actually identified that. And as I was saying at the beginning, the real advantage we have is that we can do this very extensive external validation efficiently. And it's very important to do the external validation because this shows you whether your model is going to transport to new populations and generalize, which is key if you want to actually have a model that's going to be implemented. When we externally validated this model, we looked at similar data sets. So we looked at another US private payer claims data set. We looked at data sets that had slightly different populations. So we looked at a Medicaid and a Medicare supplementary data set. We looked at whether it would transport to electronic health record data, whether it would transport to non-US data. And we see the error under the curve, although we have some drop in some of the data sets, it's still actually very good performance. An error under the curve of 0.6 or higher is generally pretty good for external validation. So this is really promising that this model seems to work well. So now if we look back to our original visualization with those 30 people who are going to have a suicidal thoughts and behavior, but in this case we've ranked them with the people of the highest risk are at the top left-hand corner and the people of the lowest risk are at the bottom right-hand corner. This is the sort of distribution you'd see based on our model. Now, without a prediction model, the best that we're told is that 3% of these people are going to have suicidal thoughts and behavior in the future. But can personalized predictions be more informative than a population average? Yes, they can. So our model is actually telling us that 6% of people are going to have a risk of 10% or higher of suicidal thoughts and behavior. So this is a lot higher than the 3% average. 20% of people are going to have a risk between 3% and 10%, so they've got a higher than average risk. 47% of people are going to have a risk between 1% and 3%, so they're slightly lower than the average. And 26% of people are going to have a much lower risk, between 0.1% and 1%. So we can stratify this population into different risks groups. But there's also lots of potential adverse events listed on packaging. So we've got this nice standardized framework set up. Why not try to apply it to lots of different outcomes? So we've got a risk of bleeding listed on the packaging for sertraline. We have seizures, angle closure glaucoma, hyponatremia. We have sexual dysfunction, hypothyroidism. There's quite a lot of outcomes. Let's see how the model does, or the framework does, when we look at all these different outcomes for prediction. On the test sets, we found that for all of these outcomes, we got pretty good performance. So error under the curves range between 0.66 and 0.88 on test sets. So this is actually pretty good consistently on all these different outcomes, even though the outcomes were very different to each other. How could these be used? Well, if we didn't have a risk prediction model for all of these outcomes, we could just look at the population average. So we looked at our data, and in our data, how many people had each of these outcomes in the following year. And we get a profile that looks like this. So this is the average risk profile, where we said rare means that it occurs between 1 in 10,000 and 1 in 1,000, uncommon it occurs in 1 in 1,000 to 1 in 100, common 1 in 100 to 1 in 10, and very common greater than 1 in 10. But let's look at some patient stories. So what if we had a 60-year-old female, she was generally healthy over the past 3 years, recently diagnosed with type 2 diabetes and has hyperlipidemia. She actually has a lower risk of many of the outcomes, so her risk profile is not average. 18-year-old female, history of skin cancer, recurrent bouts of anxiety requiring psychotherapy. She, as expected, has a much higher risk of suicidal thoughts and behavior, but a lower risk of some of the other outcomes. So her risk profile is not average. 76-year-old male with liver disease, he's got gout, diverticulitis, recently diagnosed with pancreatic cancer. He has a much higher risk for hyponatremia and seizure, and many of the other outcomes as well. So his profile does not match the average. 79-year-old female, comorbid obesity, type 2 diabetes, atrial fibrillation, congestive heart failure, prior use of NSAIDs. She actually has a much higher risk of hypothyroidism and some lower risk for suicidal thoughts and sexual function. So her profile, again, does not match the average the population would tell us. 75-year-old female, multiple comorbidities. She has multiple visits for the ER. She's had a recent admission for heart failure and renal failure. She has a much higher risk for hyponatremia, but a lower risk for sexual dysfunction. So again, she is not average. In fact, when we looked at everyone in our target population, 94% of them had a risk profile that deviated from the population average. So 94% of people had at least one outcome with an order of magnitude different from the population average. So what does this tell us? Well, it's telling us that we could use the patient level prediction to complement our characterization and our population level estimation. In the example I've given you is in potential side effects of depression, but this could be applied to a range of different disease areas. We also are able to improve on the idea of the precision medicine because we can identify the different risk groups. So we've got the high risk and the low risk groups, and that might be used at some point to help manage treatment decisions accordingly. This doesn't have to be post hoc. This could actually be integrated directly into healthcare delivery systems. So, and as a final kind of comment, I'd just like to say, if this is interesting you all, we are a very open work group. If you're interested in joining, we'd be happy to hear from you. So thank you for listening.